Hey everybody, I'm Lindsay Covington. I'm the Director of Communications and Community Engagement here at HCA Florida Lake City Hospital. And I just want to thank all of you in the room today for joining us for our next HealthCARES educational series presentation. We have a room full of some lovely people today. And then we are having this presentation online for our Facebook audience. So we're really happy for everybody who jumps on and joins us via Facebook Live. So like I said, we're here with Dr. Vasquez, and she's a general surgeon at our hospital, and she's going to talk today about weight and surgery. So I'm going to turn it over to her, and she will get going.
All right, thank you so much, Lindsay. Welcome again to the Facebook users that are coming back and seeing this healthcare series. My name is Dr. Valerie Vasquez. I'm a general surgeon here in HCA Florida Lake City Hospital. This is our lovely staff. We do have an office coming off of 90, general surgery office. So what kind of surgeries do we offer? We'll go briefly so you don't miss out on anything. Soft and skin and soft tissue surgery like lipoma, cyst, skin cancer, pilonidal soft tissue masses, lymph node biopsies. Usually some of these look very similar to these pictures. Emergency surgeries, including bowel surgeries, bowel obstruction, for gallbladder, appendix, gastric perforations, colon perforations and trauma. We do elective surgery for hernias and gallbladders. And we also offer surgery for colon cancer, colonoscopies, hemorrhoids, endoscopies. So today we're going to be briefly talking about obesity and surgery and how obesity affects surgical outcomes, as well as how obesity will preclude or kind of elective surgeries kind of steer away from surgery until you get to that healthy weight to get better outcomes. So a little bit of the outline of today, we're going to go through a brief introduction. We're going to define some common terms with weight, a statement of surgical importance, the prevalence of weight, associated problems, and briefly we'll talk about treatment of obesity, which is surgical and non-surgical. Again, we in this office, in the Lake City office, we do not offer bariatric surgery, but we could evaluate for the indications of bariatric surgery, and we could definitely refer you to some great colleagues. So obesity is basically an objective measurement that is assessed by BMI. I'm pretty sure you guys have heard about this term, the body mass index, which the BMI more than 30 would indicate obesity. Also, obesity can be measured by the body weight in excess of 120% of your ideal body weight, and or a waist-hip ratio of more than 85 in females and more than 90 in males. So obesity exposes surgical patients to increased mortality and morbidity. So it is very important when it comes to surgical patient. It increases the technical difficulties as well to the surgeon as well as to the anesthesiologist. But also surgery provides an important treatment options for the correction of obesity. So going back to the terms, what actually is ideal body weight? Ideal body weight is a theoretical weight that is considered optimal for that patient, optimal health, and it's based mainly on height, gender, and age. But it is just a theoretical weight. So we usually go by BMI, which is an actual number. So defining this BMI and what it basically what it entails in your weight. So if you have a BMI of less than 18, you're technically underweight. Normal would be from 18 to 25. Overweight would be 25 to almost 30. And already more than a 30 of BMI means that you are in the category of obese. You can also be BMI of more than 35 to 40, morbidly obese, or super obese, which is more than 50. Unfortunately, obesity is a major health crisis here in the United States. And you can see that more than 40% of the United States population is obese, more than a 30% of BMI, like more than that 30 number that we saw. It has become a significant public health issue, and with good reason. It has been billions and billions of dollars in healthcare because of this problem. And over the past 40 years, the number of people living with obesity has almost tripled. So in 2022, 2.5 billion adults aged 18 years and older were considered overweight. This corresponds to 43% of the adults here in the United States, age 18 years and older. And it has tripled almost since 1990, which was before only 25%. So the prevalence of overweight varies also by region in the world. So 31% in Asia to 67% in the Americas. So here you can see also there is a little bit of a more prevalence in overweight and obesity in women, but mainly United States is the #1 country with the obesity crisis in the world. So obesity is the second most preventable cause of death after cigarette smoking. This is how it affects your life, how it affects public health. So obesity is the second. After smoking, it's the #2, and it decreases your life expectancy by 2.4 years. It predisposes to medical and surgical diseases, both in children and adults. And we have also seen a way increase in incidence and prevalence of obesity in children. So there are many causes of obesity. So overweight and obesity results from, of course, we know an imbalance of intake, which energy intake is basically your diet, and that imbalance compared to your expenditure, which your energy expenditure is your physical activity. So in most cases, obesity is multifactorial. So you have the obesogenic environments and also psychosocial factors. So what is an obesogenic environment? This kind of like concludes like what is an obesogenic environment. It's basically a range of environment that influences people to unhealthy behaviors, to consume worse diets. We have seen that the diet has worsened throughout the years. Transportation has increased, so people don't walk mainly anymore to their jobs, or there's not enough sidewalks to walk around. Also, genetically modified organisms, we don't know what we're eating anymore. There's so many food factors that can contribute to our health and to our obesity. Also nightlife. So your sleep and awake cycle is not the same anymore. So usually when you're awake more than what you are asleep, then obviously you have more time to eat. And these hormones will also increase your risk of unhealthy behaviors. And right now, it's very common to see people eating anywhere. It's very normal. You know, like you see people eating while they're driving, while they're walking, in the trains. So people snack and eat at any time of the day, rather than before it was 3 meals a day. So it is a little bit way more common. That is a obesogenic environment. A smaller subgroup of people have a single major factor that is contributing to obesity, like medications. Like very commonly, we know that steroids will cause increase in weight gain. Or you have a certain disease like hypothyroidism, for example, which is a very common disease that will cause weight gain. Also, immobilization or any other genetic syndromes, like, for example, very commonly, trisomy 21, which they're also predisposed to weight gain. Other medications that can cause weight gain are antidepressants, some of the diabetes medications, and other psychotropic medications. So weight gain will impact mainly almost every single system in your body. Your brain, your liver, your joints, your gallbladder, digestive system. So we can go through normal or usual problems with weight gain. So in your central nervous system, weight gain can cause depression. Cardiovascular, for example, the weight gain can lead to hypertension, hyperlipidemia, ischemic heart disease, which is mainly heart attacks. Respiratory system, you can get anything that is restrictive, so asthma, or obstructive sleep apnea, which you will also hear about CPAP use at night. In GI system, you can get reflux, peptic ulcer disease, hiatal hernias, gallbladder problems. In your genitourinary disease, you can get chronic kidney disease, even infertility. And circulatory system, you can have varicose vein, blood clots, and there's so many others that are not listed here. Musculoskeletal, obviously, the heavier you are, you can get osteoarthritis, degenerative spine disease, and endocrine system, the most commonly diabetes. So when it comes to surgery, when you're a patient and a surgical patient that you come to the office, we do a preoperative assessment because every surgery, even the smallest of surgeries, has its risk. So during our history taking, we will ascertain the presence of diagnosed medical conditions and those symptoms that are associated with these medical conditions, what kind of medications you're taking, and also social history of smoking and alcohol, also drug abuse that can compound any challenges in association with your weight. So we'll record your weight, your height, and we'll establish your BMI. So we can also establish how your obesity is distributed. So a lot of times it is central obesity, like central fat, which is mainly around your abdomen. It is metabolically active, unlike the peripheral ones, which again contributes to more significant mortality. So if you think about it, central obesity can also affect way more your respiratory status. We'll assess your blood pressure, and also for your respiratory system, we'll assess if you're having sleep apnea or if you use a CPAP. So if you're coming to the office for an emergency surgery, you're probably being sent to the emergency room. And these things can be optimized further in the ER or further in the hospital with a little bit less of a time. But if you're coming in for elective surgery, for example, an elective hernia, we might delay your surgery. Might delay surgery if your BMI is more than 35. Usually a good target of BMI should be less than 35. Good blood pressure control, glucose control, and your hemoglobin A1C, which is ideal, less than 7. But if you're coming in with a hemoglobin A1C of 10, we would definitely optimize that glucose control prior to any elective surgery, given the complications that we could face after surgery. Also, improve your respiratory status. Why do we do that? To avoid these things, right? So morbidity in surgical patients is a real thing. Morbidity is basically the complications because of these glucose or BMI or hemoglobin A1C or weight, all these things that are not optimized. So for people having lunch, I guess these pictures might be a little bit gnarly, but the first one on the left, you can see this is very commonly, very common, a wound dehiscence. So wound dehiscence is when the incision completely opens because mainly an infection. The infection comes from either having some medications that contribute to decreased wound healing, like steroids, or having your glucose really high because bacteria loves glucose. So being a high risk for infection. So you can get wound dehiscence, a 30% increased risk if you are overweight or obese to develop a wound dehiscence. Surgical site infection is that SSI is 17%. It will start like this one, just like erythema, induration, redness, warmth, what we call cellulitis. Also, you have a 30% increased risk of developing an incisional hernia if you are overweight or obese, because of the pressure your abdomen or your intra-abdominal organs and fat put on top of that incision, like we can see in our gentleman on the top. Also seromas, which are basically fluid collections under the incisions, or you're also at increased risk for developing bleeding after surgery. Fat necrosis is very common as well. And most importantly, if you are getting either colon cancer resection or small bowel resections or any resection of your intestines that we have to put them back together, which is called an anastomosis, you are at 10% or 10 times more increased risk of getting that connection failed because of the weight and how the weight predisposes to your comorbidities. And also, if we did fix your umbilical hernia, then you have an increased risk of getting a recurrent umbilical hernia because of that pressure just being right there at the stitches site can increase that risk. So how do we manage obesity? We can manage it non-operatively or surgically. For example, if your problem is food addiction, then and there's a psychological component, also a physical component. It is very important for your primary care provider to be able to identify this, and you can most likely work very well with either psychiatry or psychology, group therapy, and support. Also, behavioral modifications, and you should be able to eat 3 meals a day, try not to snack between meals, and no eating after 7. You can definitely start treating your obesity starting like that. And obviously, lifestyle changes. Even 30 minutes a day of walking that you did not do before will change your behaviors, and you'll see yourself walking just a tiny bit more each and every day. There's also medications, as everybody knows, for weight loss, different mechanism of actions that the FDA has approved for weight loss. Like, for example, if your problem is appetite, just having a lot of appetite all the time, there are suppressing appetite medications like the phentermine or the topiramate. Phentermine most a little bit more of a common medication. Reducing calorie absorption, like the orlistat, which is the Ali, that you can also, I think you can even buy it over the counter, I'm not sure. But these, basically, you don't absorb what you're eating. Or other medications that can increase your metabolism, or also regulating hormones that control your hunger and satiety, which are now a little bit more common and famous. We see them in TV ads all the time, like the Wegovy, the Ozempic, and the Mounjaro. So things to consider before we just jump into these, medications for weight loss. They're used in conjunction with lifestyle changes. It's not like you're going to start this medication and you're going to forget your diet and forget your exercise, because this should be something that helps you start a normal routine, or a routine that will guide you. And then once you're in that routine with diet and exercise, you can technically come off of the medication. You don't go on these medications forever, right? So because they have side effects, a medication that you're taking for a long time, it's not something that you would like. This is something that in conjunction with your lifestyle changes should guide you to that, to changes in your habits, so you can be able to come off them. And not everyone is eligible for these medications, so they might not be effective on everybody. So what about surgical managements of obesity? Bariatric surgery is the best known and most effective treatment for obesity. And we've seen in meta-analysis and a lot of studies that it has shown that it's more effective than diet, exercise, and pharmacotherapy alone. But again, it is surgery, and all of them pose this very high risk. So how do we even consider, like, am I a good patient for bariatric surgery? How do I know if I can get, if I'm eligible to start the process of probably getting surgery? So these are the patients that at least, they can get eligible, and the insurance will cover also, which is important. If your BMI is more than 40, you can probably get a good bariatric surgeon to evaluate your case, most likely be a candidate for bariatric surgery. Or if your BMI is more than 35 and you have at least one or more obesity-related comorbidity. For example, if your BMI is more than 35, but you have high blood pressure, obstructive sleep apnea that you're using that CPAP, diabetes, or you have non-alcoholic fatty liver disease, or you had a heart attack because of your weight, or high cholesterol, you can also be eligible for surgery. Important, the other people that are also eligible are not a 35 BMI, but maybe, or a 36 BMI with no comorbidities, but you have been in social groups, in an exercise routine, in also medications to lose weight, and you have been unable to achieve this healthy weight loss sustained for a period of time, you could also be eligible for that. Contraindications for surgery would be a psychiatric illness. Usually before you get cleared for surgery, for bariatric, a bariatric surgery, you will get a psychiatric evaluation. That would be if you are determined to have a psychiatric illness leading to your weight gain, then you might not be a candidate. Because if you think about it, even if we cut your stomach to quarter size, if you do have a psychiatric illness leading to consumption of food in a compulsive manner, then you will never lose the weight. Severe cardiac disease, basically, if we take you to surgery and you can't survive and you die on the table, then you wouldn't be that candidate. Severe coagulopathy, the risk of bleeding would outweigh the risk of the surgery, you will not be a candidate. Or just inability to comply to follow-up. Because follow-up after bariatric surgery, very important. So we'll go through the most common bariatric surgeries, pretty basic. So we'll start with the adjustable gastric band. This is basically a band that chokes your stomach. This is basically what it is. It's a band that goes around the most superior portion of your stomach and basically makes a small tiny pouch that you will feed into that pouch before that band. And because that band is choking the stomach, you will feel like you can't eat anymore. So you will feel full, and the satiety will be there and decreased hunger. You have this port that goes into your subcutaneous tissue that the surgeon will increase basically the water or the air in that port, making the band tighter and tighter. So for these, the estimated weight loss is not that severe because technically we're not cutting the stomach, we're not making the stomach anatomically, any smaller other than with the band. So your weight loss would be between 15% to 60%. You could have complications, like for example, if this band slips down and it goes further down into the body, you can have severe complications, or if the band is too tight, it could erode into your stomach. Those would be some of the complications. Also, the balloon can pop, so then you lose that constriction. The good thing is it's pretty affordable with your insurance. It is reversible, so if you don't want it anymore or you're not tolerating it very well, you can just get it removed. Other things with this gastric band, it was initially very popular because it was mainly the least invasive, like they're not cutting into your stomach. But we have seen long-term band complications requiring band removal in almost half of the patients. But the patients that did keep this band without any complications, they were able to lose at least 50% of their weight and kept it for 15 years. But compared to the other surgical techniques that we're about to see, it's still inferior. It's not as good as the sleeve gastrectomy and the bypass. So the sleeve gastrectomy, I feel like it's a little bit more common than the bypass. So this procedure is almost always the one that patients go for. Basically, you're cutting the stomach and just leaving a tiny little tube of a stomach. The rest of the stomach that is removed, it's gone. Like, it gets removed from your body. It's thrown in the pathology basket. So from here, obviously this is not reversible. Once they cut it, they cut it. But it is also a restrictive pattern. So you will feel full faster. So you will feel satiety faster. This one has an estimated weight loss even higher. So 50 to 70%. The gastric band, you could probably, in average, lose only 30% of your estimated weight. So again, just like the gastric band, it limits your food intake because it's a restrictive kind of surgery. But if you think about it, we cut through here and make a staple line. So complications with these, if that staple line opens, you can have a leak. So complications like staple line bleeding and leak can be life-threatening. It is not reversible, and it's just a little bit more expensive than the gastric band. You will have, because of the portion of the stomach that was removed, you will have some important cells in the stomach that were removed as well. So you could get vitamin deficiencies like vitamin D deficiency, iron, vitamin B12. So most of these patients will also be taking supplements for the rest of their lives. The other bariatric surgery is called the Roux-en-Y gastric bypass. This one's a little bit more complicated because it's basically a restrictive surgery as well. So you are cutting the staple line, you are cutting the stomach right where those dots are. So you're making the stomach way smaller. You have a small, tiny pouch that you will keep as your stomach, way more smaller than the sleeve gastrectomy. But in the sleeve gastrectomy, you maintained your anatomy. You maintained that continuous GI from the stomach into the intestines. In this bypass, we basically bypass your entire intestines. So we make the food, the pouch, or like where the food goes, it's a way shorter span. So you don't absorb as much food or nutrients. That's kind of like how you lose your weight. You can't eat as much because your stomach is a very small pouch, and whatever you eat, it bypasses almost your entire intestines. So you don't absorb your nutrients. So common problems would be way more postoperative metabolic managements, because you will also need a lot of supplements because you will bypass all of that space where you were supposed to absorb all these nutrients. You can again have an anastomotic leak, which is a staple line. You can have that pouch can also dilate, or you can have ulcers in that area of your pouch because the stomach is touching right there really close to that small intestine, which basically the small intestine shouldn't really be exposed to any acids in the stomach as normal. It does have a lot more estimated weight loss, 60 to 70% after surgery, just because it's restrictive as well as it bypasses all the nutrition. It is partially reversible. It has the highest amount of complication rates compared to the gastric band and the sleeve. And this is the last one, which is a biliary pancreatic diversion. This surgery is very complicated. It is not, it's not done as much anymore. It is also a restrictive, right? The stomach still gets cut, and there is still a bypass on it. The difference is where we cut the small intestine and where we connect it. So the area of bypass is much longer. So you can also have a lot of metabolic abnormalities and way more estimated weight loss. So basically, the area that is moving is basically your food bolus. So it's going to be the shortest limb. And this one is going to be all of your bile duct secretions. And so technically from here to here, you can have the absorption almost. So you'll again have the metabolic derangements that you'll have to take a lot of vitamins. It will have a lot of estimated weight loss from 70 to 80%. But the risk, the overall year mortality is 1.1%, and the overall complication rates is almost 20%. So 2 out of 10 patients will have a severe complications from the surgery. Therefore, it is not it's not done anymore as common as it was before. So many analyses we have found that we have similar weight loss trend at 3 or more years post-op, with the greatest weight loss after malabsorption. So malabsorption was, again, the bypass. The ones that are restrictive are the gastric band and the sleeve. But anything that bypasses your gut will lead to more weight loss. So what can surgery offer? So usually it will worsen your gallbladder disease. So technically now, the surgeons will also opt to remove your gallbladder at the same time, so you don't get gallbladder problems after surgery. It will worsen your acid reflux, but it will improve your fatty liver disease. Also shown to be to improve your fibrosis. It will improve your diabetes. It will improve your hypertension, and it will also improve your sleep apnea. And most of all, it will improve your habits, your way of living. You're going to feel much better. Unfortunately, you will have, like we talked about, nutritional deficiencies, protein deficiency from malabsorption, iron, vitamin deficiency, folate, and all of the fat-soluble vitamins, which are A, D, E, and K, and thiamine. But it technically improves your quality of life. You know, like you're losing all this weight. Most of the people come off of their medications for blood pressure, for diabetes, their liver regenerates again. So it is something that if you are struggling with weight gain, something that you should think about it. Talk to your primary care provider. If they don't know a good bariatric surgeon, we are here to help as well. We can definitely send you to a good bariatric surgeon. Colleagues of ours that are well established. And then just remember, one day at a time, one healthy choice at a time. It is basically a progress. It is not perfection. It is just changing your entire habit. 30 minutes of walk a day will change a lot of things. And the snacking is probably one of the worst parts. Otherwise, we are done with this. Again, I'm dedicated to serving this community and supporting their needs in any way I can. If you guys have any questions, don't forget to put it in the chat. We'll be able to answer those. And if you need an appointment, book your appointment now. If we don't have any questions, then we are good to go. Thank you for watching.